Welcome to the Kaleidoscope, Healthcare in a Diverse America, from molecule to market, with your host, Sheila Thorne. Each episode highlights healthcare leaders and patients of color to discuss culturally, linguistically appropriate strategies and services. You can find this show on all major platforms, including YouTube, LinkedIn, Apple Podcasts, Spotify, and on our website, SheilaThorne.com. Now here's the host of the Kaleidoscope, Sheila Thorne.
Hello, and welcome back to the Kaleidoscope. It's good to be here again. We took a brief recess during the summer because we spend most of our time in the summer going to various conferences of Blacks, Latinos, Asians, and Native Americans, so we stay connected with community. That's one of the key principles in success, in outreach and engagement. You have to show up. You have to be in community. So we had a great summer. We reconnected with some old friends and we made some new ones because health disparities have not been eliminated. And as long as health disparities are pervasive and persistent, we're going to stay on the case of making sure that all of us understand how we have to deliver quality care to people no matter what they look like, where they come from, or what language they speak. Now, in the Kaleidoscope, we specialize in people of color, healthcare professionals of color. That's not to say our brothers and sisters of other races and ethnicities don't do a good job, but we want to highlight these folks because many times their voice isn't heard. They're not brought to the table. And because they are more likely to serve people of color, we want to be sure we have their perspective, their clinical experience, their patient experience, and their journeys as we all strive for not only elimination of health disparities, but health equity. We also make sure that our programs are in line with the national health observances that occur every month. September is Prostate Cancer Awareness Month. And we know that men in general often have a difficult time connecting in a timely way with the healthcare system. But men of color have some unique issues and perspectives, and we want to make sure you're aware of them. No matter what we hear about heart disease or diabetes or other forms of disease conditions, we often don't know what's happening in these conditions with people of color. So that's our topic for today. Certainly, these disparities are persistent. We want to make them disappear. And we not only have some of the leading national experts in a specific therapeutic area, but we also have been very pleased to have the courageous patients who have been willing to share their life experiences with us. Here's a statistic I heard recently. Every 18 minutes, a Black man is diagnosed with prostate cancer. That's daunting. A higher incidence, more aggressive disease, and we want to figure out why. Now, just imagine if you were a man of African descent and you were diagnosed, and you might want a urologist who is of the same race and ethnicity. Well, that could be challenging. The American Urological Association tells us there are about 14,000 urologists in the United States, but only 293 are African American, and only 321 are Hispanics. And there are also some female urologists, and they're usually referred to as urogynecologists. So they do exist. So if you're a man of color, African or Hispanic, and you want a urologist of the same race or ethnicity, it probably is highly unlikely because there are 20 million Black men in this country, just not enough to go around. But that doesn't mean you won't get quality care as long as your provider is culturally competent, culturally sensitive, and culturally humble. So let's get into this topic of prostate cancer. It is my special delight and privilege to introduce to you someone that I've known for a number of years, dedicated to community, a premier clinician, and certainly has been very in the forefront of educating about urologic diseases, especially prostate cancer. It's Dr. Leon Seard. And he is a physician who is currently in California. Let's bring him on, Sarah. I'd like the audience to see him as I sing his praises. Dr. Seard, welcome.
Thank you, Sheila. It's so good to be here. It's, always love doing anything with you because you do things so well, and you're just so on the pulse of everything. And I love the intro that you gave with the statistics. So it's just great
Yes.
to be here. Thank you.
Well, we're honored, Dr. Seard. And let me tell the audience a little bit about you. Dr. Seard was raised in Washington, D.C. He attended Oakwood University in Huntsville, Alabama. He earned his Bachelor of Science in Biology, graduating summa cum laude. And he then went on to receive his medical degree from Loma Linda University and completed his residency at the University of Southern California. A premier urologist, and he served at the Talbert Medical Group in Fountain Valley, California. During his tenure there, he had a number of leadership positions: chair of urology, chief of staff, chief of surgery, and after 18 years, moved his entire family back to Tennessee, where he was part of the largest urology practice in the state of Tennessee. But now he's back in California, and he clearly has been renowned in his work in urology, having won Physician of the Year award, and he also won the Frist Humanitarian Award. People might not know that Frist was the only physician, the first physician who served in the United States Senate, wasn't he, Dr. Seard?
Yes.
So his dedication and passion for urology is renowned internationally and nationally. And so today, Leon, and I hope it's okay if I call you Leon, because I figure you're a family. You're
Absolutely.
okay, thank you. I want people to really understand how this prostate cancer really is infecting or is pervasive in the Black community. And, you know, Leon, I know you're a spiritual man as well. And as I've heard you present, you often start with the scripture, Hosea 4:6. And if you share with the audience, what does that scripture say?
Well, that scripture says that people are destroyed for lack of knowledge, and it's familiar scripture. But I like to add on to the end of it, because the end of the passage says that because you have rejected knowledge.
Okay, you're kind of going in and out now. The scripture, yeah, the people perish for lack of knowledge. That's right. Okay,
yeah,
how are we doing with sound?
It's because of a refusal to get knowledge. Oh.
Okay, the sound is not too good. Sarah, there's nothing we can do about that? Let's see if we can help.
I mean, usually I don't have a I'm going to...
Hey, Sarah, what if we have Dr. Seard call in? You think that would be better than trying to do it on the computer since we've seen him?
Should I try it on my... Everything... I go to another spot, and I get a better spot and a better spot in here. I mean, in the
you know what? Stay where you are, Leon.
Move a little bit.
Sarah, can he call in?
You want me to try phone versus moving to another spot?
Yes, I think a phone would be better. Just so now that we've seen you, we can now listen to you.
Okay. All right. So you want me to use the when we call in the phone with the phone?
Yes.
I'm gonna try something. I'm going to just let's see if we can get to another spot and I can get a little better connection.
Okay.
Give me about 3 minutes.
Okay, not a problem. I'll also take the time to introduce our patient, Deputy Chief Wayne Harris, retired from the Rochester Police Department. Wayne and I have also worked on a number of programs, and as a very busy, high-ranking law enforcement professional, I thought it would be important for you to hear his story and actually learn from that patient journey and that patient experience. So we'll bring on Wayne after Dr. Seard and I have a little bit more of a conversation about prostatic disease. Sarah, what do you think? Should we just have him call in?
You trying to find a room to use?
Yeah, he's moving around. Okay. Bear with us, folks. I know you.
No problem.
I know you want to hear everything Dr. Seard says because he has some really interesting pearls of wisdom.
It's a little darker in here. I don't know
That's okay, as long as we can
if
hear
this is
you,
any
Leon.
better.
It's okay. I think we can hear you fine. We can hear you. Can you hear me?
Okay, all right.
All
I
right,
can
well,
hear
let's-
you fine, yeah.
Perfect. Well, let's keep going. We see your picture, so don't worry about the transmission of your photo. Okay. So let's start at the beginning. What is a prostate?
So a prostate is a little walnut-shaped organ. It's a part of the male reproductive system that sits just below the urinary bladder. And its purpose is just basically to provide nourishment and fluid for the sperm, for the semen.
Uh-huh. And what are the prostatic diseases? We know the prostate cancer is not the only one.
Right. So basically, in a nutshell, it's a growth problem. So we call that, I like to call that old man's disease, or benign prostatic hypertrophy, just the prostate itself grows. Then there's inflammatory or infectious diseases like prostatitis or an abscess or other infection there. And then, of course, the cancer, as you've mentioned.
So when you talk about the benign prostatic hyperplasia, that's an enlarged prostate, correct?
Correct.
So if someone is diagnosed with that, if a man is diagnosed with that, does that lead to the other diseases and to prostate cancer, or can that be treated in and of itself?
So you can have any of them at the same time or separately. You could have infection and an enlarged prostate, or you can have infection and cancer. You can have cancer and an enlarged prostate.
Okay. So then what are the risk factors? Why is it that Black men have a higher incidence of this condition and more aggressive disease?
Well, overall, the biggest risk factor for prostate cancer is age, or even benign, the enlargement of the prostate. The older a man gets, the larger his prostate grows. So you're not going to find an enlarged prostate as being a problem of younger men, but men get in their 40s and 50s and 60s and on. And same thing for prostate cancer. The biggest risk factor is age. Now, obviously, because African American men have the highest incidence of prostate cancer in the world, there is the other that is the other main risk factor. So ethnicity. Then there's a risk factor of genetics, just because of if you a family history, or there's some gene alterations that you have that can predispose you to having a prostate cancer. We don't know all the reasons behind these differences in disparities, at least as far as risk is concerned, but we know that's what they are.
So talk to me about screening. How can we encourage men of African descent to get screened, or is screening the best way to find out whether you have any of these conditions?
I think screening is very important. And what I mean by screening, that basically means getting the blood test, the PSA, or the prostate specific antigen, and the physical examination, the digital rectal examination, the DRE. Now, today we don't do the DRE quite as often as we used to, because it's not quite as reliable as the blood test. And so a lot of times when I'm speaking in communities, when I tell the brothers that, both of them is good, but at least you can get the blood test, and we can kind of spare you of that gloved, lubricated finger examination that none of us are thrilled about having. And so
that's exactly right.
Yeah, and the reason for that, even though it's still instrumental in catching things like maybe colon cancer or whatever, but as far as prostate cancer, it's not as reliable. And now we've got newer technology that's more reliable to help us with diagnosis. But the screening that comes is important, and the most important thing is have that discussion with your physician, especially if the physician looks like you, and to determine what's going to be the best approach, how often to get that screening, et cetera.
What age should we even start talking about it with your doctor?
Well, as a rule, most people, so for the majority population, if there's no risk factor, usually age 55, but for the risk factors such as African American men or family history, 40 to 45. I like to tell my brothers that start at 40, because if I tell them 40, they might get in by 45.
Right.
So I would tell them that, and but basically, if you have the family history, especially if you got more than one first degree relative with prostate cancer, your risk definitely goes up, and so you want to start at by age 40, at certainly by age 45.
So if your doctor hasn't suggested that you have this blood test, should you proactively ask for it?
Absolutely. I mean, self-advocacy is very key. And a lot of times we kind of hesitant, as brothers are hesitant to kind of speak up for ourselves when it comes to our health. But it's like, and I see many patients or I talk to people in churches and other settings that say, well, my doctor won't order it. I said, well, then you ask for it, you request it or demand it, or find another physician. But for the most part, you find if a physician looks like you're pretty much sure that they're going to be okay with getting these screening tests.
Yeah, that's important. I think most of the work that you and I have done together is about helping the community to become empowered, to proactively look for these things and ask for them if your physician has not suggested that you do it. So, okay, you take the blood test, the results come back. How do you interpret them?
Okay, so the blood test comes back abnormal. There are a number of things that can falsely elevate that blood test. So if you've had an infection of your urine or your prostate, if you've had a rather vigorous examination of the prostate, if you have had a colonoscopy within the past several weeks, or if you have even ejaculated within 48 to 72 hours prior to having the blood drawn, all those can falsely elevate it. But assuming that the elevation that we have is not due to any of those extraneous causes, then, and especially if we have more than one lab test to confirm an abnormality, the next step as a rule would be to get an MRI. We didn't always do that, but probably for the past 10 years or so, we've done that. And the MRI it's not foolproof, as none of these things are, but it's very reliable in detecting some abnormality in the prostate. And then if that comes back abnormal for sure, then the next step is a biopsy. And then depending upon what the result of the biopsy shows, then that will kind of determine, along with other factors, how the next steps and how the diagnosis, how it should be treated.
So Leon, suppose that you've had the blood test. Is there a number that you should be concerned about in terms of what the PSA tells you has been the result, or what should be the indication that you need more diagnostic treatment, more diagnostic?
Yeah, so the gold standard is any PSA above 4 is concerning, but that's not fixed in stone, because the younger you are, the lower that normal would be. So if you're in your 40s, obviously we would like to see a PSA of 2 or less. If in your 50s, no more than maybe 3.5. In your 60s, no more than 4 to 4.5. In the 70s, we extend that normal to the upper limit of normal to 6.5, and there are no normals established for men in their 80s. So it varies depending upon what age. There are some medications, like we often use for an enlarged prostate, can suppress the PSA by half. Finasteride or Proscar or dutasteride, Avodart, those medications will suppress the PSA by half. And so what the lab tells us, if you're taking those medications, we then double it to get the actual actionable level. And so that's kind of the ballpark. But we also look to see the change of the PSA over time. So we call that PSA velocity. So even if your PSA would say normal this year, and then next year it's like jumped, from maybe, let's say it's gone from 1.5 to 3.7. Well, that's a big jump in a 1 year's time. So that raises some concern. And so not only do we respond to the gross number value, we also respond to its change over time. So even if the absolute number is actually within the normal range, if that velocity is abnormal, then we become concerned and we want to go investigate further.
So what are the symptoms? What if you haven't asked for a blood test and your physician hasn't suggested it, but just yourself, what do you observe that might make you say, doctor, I really need to take this blood test? What can be some of the symptoms?
So as a rule, prostate cancer itself does not have symptoms until it's rather progressed. So, and when it starts to have symptoms with the progression, that would be maybe blood in the urine, blood in the semen, back pain, bone pain, evidence of inability to urinate, or evidence of kidney failure. But for most people, the benign prostate disease, the enlarged prostate, typically the symptoms would be a slower stream, a getting up at night to go to the bathroom, a feeling that you're not emptying your bladder completely after you go, or having to go more often, taking a few minutes to get the stream started, or stopping and starting along the way. So those are all areas of what we like to call obstructive symptoms. Now, as I said, you can have just the benign symptoms and cancer together, but typically by the time you have symptoms of prostate cancer, it's advanced. And that is kind of why it behooves us to get screened early and often, or at least consistently, to make sure that there's no problem that we get missed, because as a rule, prostate cancer does not have symptoms. And when it does have symptoms, it's beyond an area we could optimally treat it.
Well, that's interesting. I've worked in communities, as you know, as you have all over the country, and talked to all kinds of people of color. Certainly Black men have been in that group. And I've heard a couple of things that I have heard them say, and I'd just like your opinion on them. Well, you develop these prostatic diseases because you haven't had enough sex, or you've had too much sex. Does that have anything to do with it?
Well, some of the inflammatory, infectious part can have some effect if you're not, like I say, flushing the system often enough. So that's here. But in terms of actual related or causative, no, the inflammatory diseases aren't necessarily causative. There is some research that maybe people who've had some chronic inflammation, maybe, but again, by flushing the system, so to speak, kind of helps diminish that as well.
I got you. So what age would you suggest men of African descent start asking about taking a blood test, or asking their physician to help to look into that? What age?
I would say age 40.
Okay. And is that according to the guidelines, or is that because of African American men and their incidence?
That's a combination. So guidelines say for at-risk patients age 40 to 45. And so, but I tend to be a little bit more conservative, or if you want to look at it one way, or aggressive in the other way, in how I take care of my brothers and uncles and dads and sons. So.
Yeah, I see that happening with breast cancer too, Leon, and with other diseases. Very often the guidelines give you a range, but for people of color who have a higher incidence, sometimes physicians suggest earlier.
Exactly. And a lot of times we know, and I'm sure you talked about in your intro, the problem with the system often prevents us from getting the care that we need. And I just read an article not long ago that looked at the idea of what enslavement actually did to us from a health perspective. And of course, it's set up beyond of all the experimentations that we know of, but just the systematic racism that is pervasive even within the medical profession has certainly been a reason for the disparities that we experience.
Come on now, you and I could talk about that for hours, and we have on occasion with colleagues. So That doesn't stop, unfortunately. There's systemic, institutional, structural racism that prevents our folks from getting access early enough into a condition or a disease. So that's something that we've got to tackle. It's unacceptable, and it certainly is something that more people are giving some attention to. And I know you've been in the lead of that, having that conversation regarding urology diseases as well. Well,
and it's interesting, just to add, I'm here at the VA today, and we know that research shows that VA patients fare better than civilian patients in terms of prostate cancer. And that's basically because the veterans have basically the same access to care and the same care being provided. So when we control for those variables, everything, that the disparity disappears. In some cases, the survival of Black men is better when you equalize all of the parameters and the variables in terms of access to care and screening and treatment.
There you go. I hear it so often, Leon, across the board, whether it's multiple myeloma, whether it's multiple sclerosis, whether it's breast cancer, the same scenario, that with equal access, there's an improvement of outcomes. And certainly that's something that all this talk about striving for health equity and eliminating the disparities, we've got to put more action into making those things happen for everybody. And that's a constant fight and a constant struggle. What about prognosis in terms of outcomes? What do you see regarding Black men compared to other men?
So the prognosis, again, if we equalize things, the prognosis is very good. The prognosis overall is a function of the extent of the prostate cancer and the stage and the grade. And so I like to, when I'm in community talks, I tell them the 2 5-letter words, stage and grade. Grade has to do with how aggressive the prostate cancer is, and stage has to do with how much is there. And so those two things come into play. And so if the prostate cancer is confined to the prostate gland, in other words, there's no evidence of it being spread beyond the immediate confines of the prostate or elsewhere in the body, then there's a good chance that local therapy will be curative. And there's also, if it's not a very aggressive cancer and there's a small amount, you can get away with what we call active surveillance, where we don't necessarily have to treat right away. We can follow and make sure things don't move. And if they start to kind of progress, then we can intervene at that time. And that's not something that we've always had, but no, it's something certainly to be considered depending on case by case basis. But it really is a conversation between the physician, the patient. And I encourage brothers to get second or third opinions. Any physician who is taken aback or embarrassed or insulted by your suggesting that you want another opinion, that's probably somebody you should be wary of to begin with. Because I typically encourage patients, say, hey, look, you go talk to some other colleagues, somebody I could recommend or somebody you find on your own, and get the discussion. And the bottom line, I want you to be comfortable with whatever decision you make and not feel railroaded one way or the other, because the bottom line, it's your body and you have to do what's best for you. And that may or may not be what I recommend or what the literature or books recommend.
I wish that opinion was shared by many more of your colleagues who may not be of color. That's important. But again, that's about the empowerment, taking charge and control of your health, isn't it?
Yes.
So that it's your body. Okay, so that's certainly something very important. Well, I want to bring in Deputy Chief Wayne Harris, Sarah, to this conversation, because when you put a face to the condition, when you make sure that you know what the journey is like, it's nothing better than hearing it from somebody. It's my pleasure to introduce Deputy Chief Wayne Harris, retired from the Rochester Police Department. And Sarah, is that background noise our fault or? No, it's not our fault. Okay, Wayne, can you hear us?
I can hear you, yes.
Okay, great. Before you start, Wayne, I love that you're courageous enough to come on and talk about something that's very sensitive, mostly among men. Let me tell you about Deputy Chief Harris. He served over 30 years with the Rochester, New York Police Department. He's currently board chair of another group that I've worked with, Law Enforcement Action Partnership. And he's a
Actually, passport chair. I'm
passport chair. Thank you.
treasurer now.
Got to
Yeah.
update that resume. You move fast, Wayne, okay?
So sometimes.
And he's also a former national executive board member of the National Organization of Noble National Organization of Black Law Enforcement Executives. He's vice president of the board of directors for the MK Gandhi Institute. Is that still true?
No, I actually have not. I do need to update my resume. So yes, that is no longer true as well.
But without doubt, Deputy Chief is one of the nation's leading law enforcement professionals, very busy schedule, even though he's retired, very active in terms of police reform, community policing, and has a number of certificates with regards to firearms and implicit bias and procedural justice. And he also has a Bachelor of Science degree from organizational management and criminal justice education, a graduate of the FBI National Academy. I say all of that to say that how in the world did you have time to take care of your health?
Well, that's an interesting story. It started following COVID, and it wasn't something that I sought out. It was my doctor who, following COVID, I hadn't seen him for a while. He put me through a litany of examinations, one of which happened to be blood work. And as the good doctor was mentioning, my PSA showed as a 4. And it was enough to trigger an MRI. And the MRI actually identified 2 lesions on my prostate.
Huh. So you had no symptoms, so to speak, with regards
I had no symptoms at all. I had no back pain. There was no blood in my urine. There was no discomfort of any kind. Sheila, you and I work close on a number of projects, and I was going about my busy schedule, traveling all over the country, and really had no idea that I had a situation developing. And if it had not been for that blood work, I would have had no idea that I was ill.
Well, and that was a good thing. Mind telling us your age, Wayne?
At the time of my diagnosis, I was 59, about to turn 60.
Okay. And this was an annual physical exam that you have as a normal course?
I was getting an annual physical examination up until the time when COVID hit, and then everything sort of shut down. So I had not seen my doctor, and I had not had the regular examinations that he usually prescribed for me. Mm-hmm. But once things began to slow down with COVID and we were getting back into contact with people in the rest of the world, he sent me for, my cardiologist, my urologist, and again, the work. So that just happened to be the time when it triggered that my PSA was elevated.
Any family member with a problem in this area?
No, and it's interesting. The doctor told me something that I hadn't been aware of. I had the digital rectal examination before. The way I ended up with the urologist was because during one of the DREs, my doctor felt what he perceived to be an abnormality. So he sent me to a urologist, and I had an examination. I actually had actual physical examination, didn't have an MRI done at that point, and it was fine. So, I had a relationship with the urologist. So when the PSA and even having the blood work done, never really knew what tests were being done in my blood work until time as it came back that my PSA was high.
Interesting. And you happen to have found an African-American urologist.
I did, yes.
Yes, and that certainly is a rare occurrence for sure. So what was your first reaction when you heard that there was something to be concerned about here?
So that wasn't a very good occasion. So I did not find out from my doctor. And I have this conversation a lot because I like to tell my story, especially to Black men, because we don't look after ourselves as much as we should. We don't have primary physicians. And I encourage young Black men or Black men of any age, if they don't have a primary, to get themselves a primary. The way I found out that I had cancer was actually through my MyChart app. So because the MyChart application sends you your test results at the same time that it sends your doctor your test results, I was actually at home in my office, and my phone flashed, and I checked my messages, and it basically told me that I had cancer on my phone.
Wow.
So I felt I was hurt. I was frightened.
Mm.
I immediately called my wife. My wife actually works at home too. So she was downstairs. I called her upstairs, showed her my phone. She immediately recognized what it was. We cried. To be very honest with you, we were shell shocked. And there were minutes of kind of absorbing what it was that we had just read. I immediately called my primary physician. He was sympathetic, but he's a primary and really couldn't offer a whole lot of help for me. I called my urologist. Unfortunately, it took him quite a while to get back to me. So I didn't have any real, I didn't have an outlet. I didn't have anyone to really help me through what I was experiencing at that point. And it was hard to navigate for me. It really was. So it was difficult. That was the most difficult time for it.
Saying
That was the second most difficult time. The most difficult portion of this entire experience was the biopsy, because to get to where my lesions were, they had to go through my urethra, and that caused some internal challenges that I won't share.
Not very pleasant. Not very pleasant.
Yeah, I won't share it with the audience because I'm smiling now, but it wasn't a smiling matter as I was experiencing it.
Now, Leon, you heard his story about how he found out he had it. Is that the normal way this actually happens, or was this unusual, or was this an anomaly?
Well, as I was listening, I was like, "Oh my God, that's crazy." Most my chart, or I shouldn't say maybe not most, but certainly ours at UCI has a provision that there's certain results that don't get released to the patient. And so those results have to come from the physician itself, and biopsy results is one of those. And so, that's really unfortunate, and really just my heart goes out because of that. But that's a terrible way to find out. And then with regard to the biopsy itself as well, African American men often have their cancers in the area that's more difficult to reach. And so I'm not sure if Chief Harris had a fusion biopsy, where they use the MRI to direct. I like to say the MRI is the road map, and the live ultrasound is the interstate highway to get you there. But that would kind of make that a little bit easier, and hopefully there was some appropriate anesthesia given, some local numbing. Sometimes like going to the dentist, sometimes that is insufficient, but it should really kind of blunt a lot of the discomfort and certainly the pain when you're having a biopsy. But my heart goes out to them. So.
I'm going to say no, sir. Unfortunately, I'm going to say no. There was very little numbing involved. I mean, I believe it was they went through the rectum to approach to where my lesions were. Unfortunately, again, they had to pass the needle through my urethra, and I believe there was a numbing agent used, but unfortunately, passing through that particularly sensitive portion of an anatomy, it didn't help a great deal, and unfortunately caused not only some clotting, but a lot of internal bleeding, and it ended up creating a situation that was excruciating.
And I might add that one of the most important things as a physician, and we often are negligent here, is preparing patients for what they might experience.
Yes.
I think it probably would have been easier. I mean, even before I do a biopsy, and I'm doing it, and before I actually take a specimen, I will fire the needle so the patient will hear it. So they won't be alarmed when they hear this popping noise, with this probe that's in their rectum, and And what is that? So if you hear it beforehand, at least it's okay. I know what that is. And
He had done that. He had done that.
Oh, he
Okay,
did.
good.
Okay.
Yeah.
Okay.
Good.
Well, man, I know when you're a man of action, you don't let things stop you or get you down. And I was also, I think, I don't know when in the journey, I was one of the people you called
Yes, you are.
to have a conversation about where you could get help or support. So, okay, you cried, you were frightened, it was unpleasant, it was painful, but what did you do next? What was your plan of action?
So I was stage 1. We actually caught it very, very early, and I had a number of options available to me. As the doctor indicated already, I could have just surveilled it and really done nothing with it. But my course took a couple of interesting turns. I asked for a second opinion, and my wife and I went in and we met with this young man who was probably a very, very nice young doctor, and I tell this story often, so I hope he doesn't mind, but he looked like he was about 12. And I thought, okay, and God bless him, he came very well prepared. He had charts and everything all laid out, and he was brilliant and very, I'm sure, very, very capable. But I wanted someone a little bit more seasoned. So I went back and I spoke with my primary, and I said, he was great, but is there someone just a little bit more seasoned that I can speak to? And he prescribed, or actually he recommended a radiation oncologist to me. And I went in and, my wife and I met with him, and he said, I have a problem with your MRI. And it sort of, took me back, and I said, what's the problem? He said, your MRI, or the MRI, should not have picked up your cancer. And I asked him why. He said, because the machine isn't designed to pick up your cancer unless the, I believe you said the grade of it, or the grading of it, Doc, is different than what you've been told up until this point, genetically, that it's not changing, your stage, like your stage 1, and we've caught it early, but it might be of a more aggressive style than what you've been told up until this point. And I said, well, how can we find out? And he said that there's a test that we can do on the biopsy material that we've already taken, but insurance companies may not cover it because it's an experimental test. It's not done on a normal basis. I said, well, how much does it cost? And he said around $300. And I said, well, okay, I'll give you $300 if that's all it costs. Take the $300, but let's find out. In the back of my mind, I was wondering, okay, I've gone through, 2 urologists. Neither of them had mentioned that there was a concern with the MRI and it should not have picked up my cancer. Why is it that this gentleman is saying that something might be up with my 2 lesions here? So as it turned out, he was right, that the cancer that I had was of the kind that could have potentially turned a little bit more problematic had I just left it alone. So my options were a couple of things. I could have opted for the surgery, which would have taken me out of commission for a little while. I could have surveilled it because it was just stage 1 and I was still am in relatively decent condition. Or I could have done some radiation treatments, which could have taken a couple of different forms. I could have just done radiation beaming, or I could have done radiation seeding. So I opted to have 2 things done. I had radiation seeding done, where they actually went in through my perineum and seeded my prostate. They got about a 95% coverage on my prostate with a number of radioactive isotopes. And then about a month after that procedure, they put me through about 23 days of radiation beaming to follow it up. So that seems to have done the trick, because that was 2 years ago yesterday.
Okay.
As a matter of fact. And I see someone every 3 months, whether it's my urologist or my oncologist. And my last checkup, which was about 2 weeks ago with my oncologist, my PSA was at a 0.3. And the expectation is that it would go even lower, probably my next time around. So I'm encouraged.
That's
And
a story. Yeah.
I consider myself pretty blessed.
Absolutely. And you and I talked about that, Wayne. And I wanted to go a few extra minutes to go through this, Leon, not to frighten anybody that's hearing this or listening to this, but to show that you've got to be a partner in your treatment. You've got to be a partner in your care. And you've got to get a variety of people that you can reason with and talk to that will give you the best direction. But ultimately, it's your decision. And this is Leon?
Exactly, I agree. And what hearing Chief's story just reminds me of something I always say. It's a quote. I don't know if some say it's from Hippocrates, some say it's from William Osler, the father of modern medicine. But it says it's not so much what disease the patient has, but what patient has the disease.
Absolutely.
And that's very important for our cohort, our family, because there are certain things that come inherent of being a Black person in America that gives us a different type. We're not a statistic. We're not just this diagnosis. You have to treat us appropriate to who we are as individuals.
Exactly.
Thinking of us as being a spiritual person, being a cultural person, being a social person. All those things come together. You just can't say, okay, well, you got this disease and this is how we should treat it based on that. No, it's more than that. And so Chief's experience kind of really echoed that to me, that there was some consideration for who he was and what he wanted to do, what was going to be best for him. And I think that's something that needs to be remembered. And again, it's a team effort.
Yes.
Yeah, and one of the things that frustrated me with some of the conversations that I had surrounding my cancer, and some of the meetings that I had, I wasn't getting a lot of information. And as a police officer, we work best with information. And when and some of the people that I was speaking with, and not the young man who clearly came very, very well prepared, but in some of the conversations that I was having, when I was being met with generalities and specifics to my condition and who I was as a human being, someone of Black heritage, of being 60 years old, I'm heavier than I need to. I'm not as heavy as I was then, but I was heavy at the time. I wanted someone to speak to me about my specifics, and when I was just getting general information, very frustrated with that. So I would tell people right now, especially Black men that are listening to this podcast, when you're having these conversations with your doctor, when you're having conversations with a physical assist or a physician's assistant, make sure they're telling you information that is specific to you. Don't accept just general information. Make sure they're telling you the stuff that you need to hear. Make sure they're telling your family the stuff that they need to hear so that they can assist you in your journey. It's critically important. And I've been going around ever since this has occurred to me or happened to me. I've been going around telling Black men, please go get yourself checked. Please, if you have not, go get yourself checked.
Absolutely. The experience definitely turns you not only and strengthens you as a self-advocate, but you become an advocate for our community and our brotherhood. Well, this has been an enlightening conversation. And again, you need to know the truth. You need to know the facts. As Dr. Seard said, it's more important to know what patient has a disease than what disease the patient has. And all of that is part of our journey as people of color in this country. We think about Harry Belafonte, Sidney Poitier, Desmond Tutu, Al Roker, Major Colin Powell, Tiger Woods' father, Earl Woods, and all of these men. Nelson Mandela had prostate cancer, and many of them survived it and died from something else. but they were diagnosed in their 60s, 70s, 50s. So this is an equal opportunity condition. And so if there was any one thing, Dr. Seard, that you would tell those who are listening and will be seeing this, what would it be? Men of African descent.
Men of African descent, take control of your health. As a rule, the women are always good about taking care of themselves. And as I look at breast cancer is kind of the analogous thing in terms of oncology as prostate cancer, but there's so much more funding for breast cancer than it is for prostate cancer.
Yes.
But women are engaged in self-advocates. And so I encourage you to take control. And then I appeal to a text that's talked about the woman with the issue of blood. And the text in Mark 5 says, when she had heard about Jesus, basically when she got some information. So I encourage men to get the information that is necessary. Extract it, find it yourself, or find somebody that says, I need to know about this. Tell me about this. So information and taking control.
Knowledge really is power, though it may be a cliche. Deputy Chief, what advice would you give to the brothers?
So talk to other brothers. If you have family members that have gone through anything like this, brothers, uncles, fathers, just friends, find out the information. If you don't have a primary physician, get a primary physician. And let me just take a moment to say why I have one. As a police officer, obviously, we get physical examinations all the time. And I remember as a young officer, I would go to get a physical examination. And unfortunately, I was seeing different doctors every time I would go in there. And I would have to explain my medical history every time I went in. And that, after a while, that just got annoying. So I ended up, speaking to a doctor that I had known in one of the emergency rooms in one of the many hospitals there in the Rochester area, and said, you know what, this is happening to me. I'm tired of this. Can you recommend someone that is accepting patients? I'm looking to have someone as a primary. And he sent me to someone that I sat down. I met with this person. I've been with this doctor now for 25 years. He's been a godsend to me. He's a friend of mine now. He knows my family history. He knows my history. He's my daughter's doctor. That's what we need and that's what we need. And if you can afford it, if you have health care and health insurance that can cover it, I highly encourage men to find themselves a primary physician that can get to know you, that can get to know your medical history, and that can help you when that time hits, because it's going to hit. If not, please find a way to make sure you get yourself into some place that can check you and find, or at least help to identify if there is a problem.
We're living at a time when people of African descent are in the forefront of not only politics, but education, of healthcare. We need brothers like Deputy Chief Harris and Dr. Seard to be around a long time to help us be the best that we can be with the time we have on this earth, and getting ahead of your health, taking charge of your health. That's all part of the fabric of what it's like to be Black in America. And certainly it's not all about money and material things. It's about knowing that you are a vessel. You are God's children, and you need to take care of that vessel and treat it wisely. I'm so encouraged and inspired by both of you. I hope our listeners and those who may be watching this on YouTube later will be as well. There is help out there. So take charge and control of your health, because quality, affordable, equitable, culturally competent healthcare is not a privilege. It's a civil right. Thank you both for joining us.
Thank you. And thank you for doing this, Sheila.
Okay, it sounds good.
Thanks for having me, Sheila. Great job. Thanks a lot.
My pleasure. Thank you both.
All right.
Stay on for a few minutes, please.
You've been tuning into The Kaleidoscope, Healthcare in a Diverse America from Molecule to Market, with your host, Sheila Thorne. You can find more episodes on all the major platforms, including YouTube, LinkedIn, Apple Podcasts, Spotify, and on our website, SheilaThorne.com. Thank you for your positive reviews, comments, questions, and for sharing this show with others.